voltage meghidatzen.
All right, good morning, and thank you. I'm going to talk about persistent post-concussion syndrome, PTSD, and hyperbaric oxygen, and essentially review all the studies that have so far appeared in the literature. The Army HOPS study has been presented in various situations, but it's not out yet, not published. So. Okay, well, the first thing I want to do is just go through a very short review of brain anatomy, traumatic brain injury, so we all have a good idea of what we're talking about when you look at the data in these studies. The brain, composed of neurons, or glial cells. It used to be thought that the neurons were the only component of the brain that had anything to do with thinking. It's now appreciated that the glia do more than nourish and support the cells. If we look at all the neurons, you can think of them as small trees. They have branches, receive information from other neurons that touch them. Electrically, the charges are summed through the trunk of the tree or cell body and passes out through a single axon that then branches like a root system to touch. By the time we're adults, maybe 100 to 1,000 other cells. Great diversity. And they come, of course, in all shapes and sizes. And they're arranged in three-dimensional orientation that's the most complex thing in the world. And when you look at these photomicrographs, they're just so beautiful, but it's easy to see the complexity of the brain. The glial cells, as it turns out, always thought to just nourish and support, in fact, modulate the neurons. They can influence blood flow, they have electrical activity, they communicate with the neurons, they have stem cell capability. They're 9 times as plentiful. The figure previously used for neurons was about 10 billion that were born with, and now the figure is estimated to be about 100 billion, so we have 900 billion glial cells in support. And interestingly, I saw this quote here in an article that thought to be responsible for processing, creativity, imagination, and our thinking mind. And here's just a picture of them, the schematics, the different colored glia as they're attaching to the neurons and influencing them. You see them here, neurons in red, the astrocytes, glial cells are in green. Okay, well, neurons and glial cells are distributed in 2 rough, different types of tissue, roughly different types of tissue. We have gray matter and white matter. The gray matter is the dense concentration that's around the outside of the brain. So we essentially have a cap of denser tissue around the outside. And then we have a deep gray matter, basal ganglia, thalamus connecting to the midbrain and brainstem, which is another deep concentration. And then connecting all of that is the very flimsy white matter, which can be thought of as the cable in the brain. Very fragile, 60-some% fat. I like to think of it as kind of organized mayonnaise. And then all of these little neurons and little trees are arranged in forests throughout the brain that give us function. And Dr. Slade and Dr. Briner both showed slides showing all of the different functional areas in the brain. As it turns out, though, this isn't so cut and dry. In fact, given the connectivity, if you think of 100 billion brain cells making 100 to 1,000 connections each, everything is connected to everything. And a couple of years ago, they did a functional MRI study, real-time blood flow, with some students at Berkeley. And they were mapping the location of visual images. They showed them, I believe it was 900 images. And what they found was the visual cortex, which is that little area back here. If you were to estimate, given all of the folds, the gyri and the sulci of the entire brain, what percentage of the brain's cortex do you think the visual cortex is looking at this map? It's pretty small. In fact, what they found was visual imagery was stored in 20% of the brain. So we have the function, while we've tried to identify these major functional neuroanatomical areas, in fact, things are distributed pretty widely. And here are the white matter tracks prior to, and this has been much of the problem with traumatic brain injury. Mild traumatic brain injury, primary injury, is in the white matter. And with increasing force, you injure more of the white matter, and eventually you injure the gray matter as well. Well, all of these years there's been no way to image it. CT scanning doesn't pick it up. Typical MRI does not until late, usually, and you might get some T2 hyperintensities, a millimeter in size, but for the most part it's been invisible. In fact, it's all over SPECT. It's a very abnormal pattern that you can see. But finally now, with diffusion tensor imaging tractography that tracks the white matter, the computer will give a different color to each different directional orientation of the white matter. So as water moves in direction along the white matter tracks, the signal can be picked up by the computer after the radio frequency pulses, and you can see all the different directions for the very broad tracks of white matter throughout the brain. You can see that it's just incredibly detailed and complicated. Okay, so TBI, as we know, is a done degenerative non-congenital insult to the brain from an external mechanical force, possibly leading to permanent or temporary impairment of a variety of different functions that are associated with diminished or altered state of consciousness. You've seen all these figures, you're pretty familiar with them. Actually, I just saw the Department of Defense had put out something in a publication, and there now, this figure is estimated up to 3.5 million. You know, mild TBI has been called a silent epidemic for many, many years, because if you think about it, so many of the sports concussions, so many of the falls, the injuries that we have at home or in our daily life, people don't go to the emergency room to, or don't go for evaluation, so they don't show up on any type of hospital survey, ledger, ICD-9 codes for emergency department visits. So there's this huge iceberg of mild traumatic brain injury out there, and the more that people are aware of it, the numbers keep going up. All right, so what happens in traumatic brain injury? If we just take the classic flexion extension, or I should say deceleration injury, a fall, or a blow to the head of any type, we have a brain and a head in motion, and suddenly it stops moving, at least the skull does. But the brain is mobile. It's floating in a bag of liquid, and so what happens? It impacts the inside of the skull. And then, of course, ratchets back and forth. If you now add torque to this, or twisting motion, you get a ratcheting of the brain between the falx and all of the cartilaginous structures in the brain as well. And there's a primary injury and a secondary injury. The primary one is the direct contact. So going from the outside in, you know, scalp, soft tissue contusion, even a skull fracture. And what has been ignored for many, many years until an article finally was published last year in Veterans is what happens to the dura. I mean, if you injure the outside, you can injure the skull, and you injure the brain underneath, and the dura is between the two. We ought to injure the dura. Well, if you know, one of the primary symptoms with traumatic brain injury is headache. So where does headache come from? The brain has no sense to it, kind of. But it is not a sensate organ. So, you know, cutting, burning, twisting, doing whatever to the brain tissue does not have a sensory component that we can then sense injury to the brain. The dura has all of the sensation, and that's the protective cover for us. So if you're injuring the cover, you know, it's something's wrong, it's an alert, etc. And that's the protective mechanism for the brain. Well, what they did was they did MRI, and typically if you do an MRI for trauma, what do? You usually do a non-contrast study. You're not looking for vascularity, tumor vascularity, for instance. What they did was MRI with and without contrast in these veterans, and they found that 54% of them, the dura lit up. And of course, headache is a prominent symptom, and there it was. We had our explanation. So in all these years, when you don't have the imaging, you don't have the science to explain something, what do? We call it a psychiatric disorder. Now with the imaging, we're finding all of the biology that's underneath. So we have the direct contusion, and then you've got the acceleration, deceleration component. And what does that do to all the organized maynays? If you've got a very dense cap connected by a flimsy structure to a deeper one, when you flex the brain, you break the white matter connections. And that's what happens in TBI. So if we look at this little color diagram from the top of the brain, what is this? This is where you separate the vessels from the skull, from the dura, and get epidural and subdural bleeds. Here are the direct contusion areas where the inferior frontal lobes, orbital frontal lobes, and anterior temporal lobes impact the middle and inferior fossa in the brain, the bone, and of course the back as well, since we're getting that flexion extension move. And this, on the sagittal view, is very, very underappreciated, but this is all of the white matter injury that's going to be distributed throughout. If we had a transverse section, you would see all of that. I'll show it on some of the stuff here in a minute. So what happens to the organized mayonnaise in a mild traumatic brain injury is you don't necessarily have to divide the axon. What you damage is the cytoskeleton, the transport system of it, and that eventually can separate the axon, or I should say decay. So what we're generating here is a little wound in the brain. And if you look at that on photographs, that's exactly what you see. These are all the damaged axons that have been divided. And when they do, the transport system can still keep flowing stuff down there. You get these retraction balls at the end where fluid builds up. So what we've got are microscopic wounds. Now, the brain is a solid liquid substance. What happens when you put an expansile object right in the middle of tissue? If you look at the micrographs of the capillaries and how they invest the brain, the capillaries surround each neuron almost like a little bush. And if you expand the size of the neuron or any structure, what you do is you compress those small blood vessels. So what we're doing is we generate ischemia and a wound around here, which is going to have what? An ischemic penumbra. If we have a large enough area of damaged tissue, we're going to have what we saw on one of the slides that the doctors were showing yesterday, Dr. Steve Walk and others, who have a central core that will die, and then a surrounding area that can still be alive. So we've got this distributed throughout the brain on a microscopic level. Is that big enough to be seen on an MRI? No. But indirectly, with the compression of this in white matter, you knock out cable, and you're not going to have the electrical transmission. And how does that show up? It's indirectly with decreased blood flow in the cortex on functional MRI, SPECT, PET, etc. So here are these on, this is a statistical parametric mapping map, which Dr. Hibskin and Dr. Gusler are going to show. And if you take a look, where's the damage in this mild traumatic brain injury? It's all throughout the white matter. All of the organized mayonnaise, which has been damaged in that flexion injury. And it doesn't show up on MRI. Here is diffusion tractography, and this was shown yesterday also in a slide. These are the sagittal views, and you can see this is the corpus callosum now coming up on one side. And remember what I was saying, the computer will give it a different color with each different direction of the white matter. So what we have is for one side, you'll see this brownish and the green here, but look what's happened. This is intact in full length. Look at all of these truncated white matter tracts. Dr. Hendricks, by the way, has treated a case where they were able to do this before and after treatment and shown hyperbaric oxygen restoring some of these tracts. Well, if we look at these cables and see what's happened, and how we're damaging it throughout a bundle of cable, and just on the side, what's the other area that's primarily injured in traumatic brain injury? Is the hippocampus. Hippocampus is a short-term memory organ for the brain. What is one of the primary symptoms of post-concussion syndrome? It's loss of short-term memory. And the reason is it sits, it's a medial structure to the temporal lobe, and it's sitting right against the bony base of the skull. And that, coupled with its vasculature and the way it's tethered, is one of the first things that's damaged. So that's the primary injury. Once you form that wound, though, and there's any tissue damage, what happens? We have a secondary injury. It's the inflammatory reaction. Anytime there's any tissue damage, you will trigger all of the inflammatory cascade, which results in edema formation, little retraction balls, compression of tissue. Actually, the contraction balls form edema around them. Reduced blood flow, reduced oxygen, excitatory amino acid elaboration, free radical damage, lipid peroxidation and cell death, and damage. And just a quick aside on blast injury. Blast injury has 4 components to it. Primary blast wave and secondary flying debris can cause injury. Tertiary injury caused by acceleration of the body and the blast wind getting thrown into something. And the quaternary one, flash burns, chemical smoke inhalation, and so on. But if we look at the direct blast force and the blast wave that follows, what happens, the primary injury is to the lungs. And Tom Fox was the one who was first brought this up and was thinking about it. If you look, and Steve Reimers now has done a bit of research on it. There's a paper we hope is going to get published sometime, but it was shown at a couple of meetings, HBOT 2012, and it was, I believe, also a UHMS meeting. And if you look at the mortality from blast, where is it? It's all from lung injury. So the greater the blast, the greater the lung damage. Eventually it's a disruption of the lungs, and people die from that, massive air embolism, hypoxia, and so on. But for the lower level injuries, and I say lower level, the degree of injury that doesn't kill, in fact, the blast force is above the level, threshold for microscopic injury to the lungs. So in fact, what may be happening, and this is why blast injury, at least in my experience, and now from stuff that's getting published, seems to be a more complicated and serious injury than just a simple traumatic brain injury. Why? We're releasing bubbles into the circulation. So we've got a combination of decompression sickness as well as the traumatic brain injury. If we look at the veterans that I treated in our study, and I go back to treatment of chronic decompression sickness, what are the two symptom locations where we have a lot of trouble getting recovery function? Inner ear and joint. So people with chronic decompression sickness involving the inner ear and joint, I tell them up front, there's a very low likelihood I'm going to be able to improve those symptoms. And those two were the most resistant symptoms in our veterans with blast injury. So, indirect information. Well, in addition, so we've got a negative pressure wave that can also generate bubbles. I'll show that in a second. There's kinetic energy transfer from the large blood vessels, so the blast, sending a blast wave up through our vessels into the brain. There is mechanical irritation of J receptors in the lungs that cause apnea. I don't know if you've talked to some of these veterans, but if you talk to enough of them, they will give you a report that they were laying there dead and their buddies started to do CPR on them. And what is happening is it's an induced apnea secondary to the injury. In addition, there are chemoreceptors that lead to a bradycardia and vasodilatation, contributing further to hypoxemia. And so the conclusion is blast brain injury is an atypical, complicated form of traumatic brain injury. Well, here's the blast wave, and there's a difference for thermobaric explosives and high explosives, the blue. But the point is, after the blast wave and increase in pressure, there's this negative wave that follows. And given that this is occurring over 50 to 100 milliseconds, 150 milliseconds, you think of the pressurization, it might be possible, we haven't done the theoretical calculations on this, but you may be able to de novo pull gas out of solution and form bubbles just from that negative pressure wave. Here are the models of this, looking at a helmeted one and pressure in the brain. If we look at the blast wave, here it is. Here's our model, with a human model with the brain here. And our pressure legend for 2.25 bar, which is 2.25 atmospheres roughly. And you see what happens. The blast wave is not necessarily completely evenly distributed. There are peaks in place. And when it hits the skull, you see what happens. It's unevenly distributed in the brain between the helmet and the model. You can see the high pressure here. It's lower up front. It's even lower back here. But then in the brain, right underneath, we've got the maximum pressure here, and then differential distributed around. So we get an uneven distribution of pressure. Well, it turns out that once initiated, traumatic brain injury really is no different from any other injury. You know, contusion to the muscle, even a broken bone. From start to finish, it's stereotypic because it involves an inflammatory reaction. So I've used this analogy. It's like taking a DVD for every little teeny wound in the body, and you plug the DVD in, and it plays from start to finish. And what is the evolution of acute wounding is chronic wounding, scar formation, etc. And of course, in this case, the scars don't necessarily heal. We have unhealed wounds. No different really from a diabetic wound. But the result is, as I was talking about a little bit earlier there with the ischemic penumbra, we have microscopic wounds that are distributed throughout the gray and white matter, primarily in the white matter, and they're consisting of living, we believe, functional brain tissue, not yet dead, as well as some dead tissue. So here's a little model I showed yesterday, the Marx model with radiation entry. Really, there's no difference when you think of expansion of edema, especially in a closed space. You're getting these. Okay, well, just a very quick definition of PTSD, because we're going to talk about this in these studies. It is formally classified as an anxiety disorder, precipitated by experience of intense fear or horror while exposed to a traumatic, especially life-threatening event. And it's characterized by four things: intrusive, recurring thoughts or images, avoidance, hyperarousal, and diminished emotional responsiveness. And it's got to be present for at least a month. But it turns out once you have it, most people don't get rid of it. It's a long-standing condition. Now, some of the conditions, some of the treatments now are showing that we can lessen this, and even with hyperbaric oxygen, maybe cure this. But another comment I wanted to make about this, you've seen it, it's all over the news, it's in every DOD epistle, that nobody can tell the difference between TBI and PTSD. And why is that? Well, if you look at Dr. Heidi Theriault, who was Fort Carson, the Army psychologist, her point is, well, yes, you can. And you do it by what's called structured interview. Well, it's no different than what you do as any healthcare provider, a physician, sitting down and talking to a patient. You start with the event and you go forward. If you have an injury and you're symptomatic from the time of that injury, well, it's pretty much an injury to whatever organ system is giving you those symptoms. And in the case of the brain, it's a traumatic brain injury. PTSD is not, or the symptoms of PTSD, all of this, are in fact not intrusive thoughts, avoidance, hyperarousal, emotional responsiveness. None of this is part of an acute traumatic brain injury. Post-concussion syndrome, yes. So if you sit down and you can identify the actual traumatic event and walk them through this and find out that they're symptomatic from either the time of the event or very shortly after, you can make the diagnosis. Well, the problem is that the symptom complex with all of the other symptoms that are attributed to PTSD, where did this come about? Came about after the Vietnam War. And what happened in the Vietnam War? What were the primary munitions that were used by the Viet Cong and North Vietnamese? Booby traps, mines, rocket-propelled grenades. Almost identical to what we've done in Iraq and Afghanistan. And how many of the injured that came back with PTSD also had brain injury, but nobody appreciated it. Nobody even questioned them about it. And so what we've got is a definition at a time of PTSD that likely included the symptoms of traumatic brain injury, or I should say the subsequent post-concussion syndrome, considered that included the symptoms of traumatic brain injury that nobody has ever tried to separate. Okay, what's hyperbaric oxygen? We talked about this. I'm going to keep pounding this home. Treatment for wounds in any location, in any duration. And of course, what we're doing is gene therapy. So let's go through all of these studies. And I just want to give you a little bit of the history of how this. Dr. Duncan gave some of it, but we made countless presentations in Washington, starting in February of 2001 at the NIH. We then went to Walter Reed in January of 2004, and we offered to treat veterans for free. If they would test them before, image them before, send them down to New Orleans, I would treat them, send them back, they could repeat the testing. And as it turns out, we met with the PM&R group there, and while I was there, my roommate from medical school, I had heard, was at Walter Reed. It turns out he was the medical director. So next thing you know, we were in his office, and I made the offer, and long story short, we couldn't get it done. So I put out a little thing that I would treat veterans for free, and ended up in USA Today. We meanwhile made multiple legislative approaches and proposals. We had one to put chambers in Iraq or forward edges battle plan. Steve Reiners was going to equip some Connex boxes with multi-place chambers. We couldn't get it funded. And then finally, Dr. Duncan, Mr. Hoffman, and I, who recently deceased, it was mostly me on the phone, son, visited 300 congressional members, and we got the appropriation that we're now currently using to fund the study that we're doing in Louisiana. Well, meanwhile, what had happened, Dr. Eddie Zahn had a good friend, has a good friend, Dr. Judge and General Pat Maney, lives in Fort Walton Beach. And Mr. Hoffman is the ex-Secretary of the Army under Gerald Ford. And his legacy was that he kept seeing the PTSD and Agent Orange complaints that were coming out of Vietnam, and he tried to get Army medical to address these, research them, and so on. And they slow rolled him until he was out, changed administration, Carter came in, and that was it. And so what happened though, since then, he stayed very active with the Department of Defense, the State Department, and after we went into Afghanistan, he was asked to help recruit the rebuilding team that would go in and rebuild political infrastructure for Afghanistan. So he tapped his good buddy, General Maney, 37-year Army Reservist Brigadier General, Florida State Judge. General Maney went over there 12 months into his tour. He was blown up in their armored SUV, unconscious. Spent 10 days there, was dysfunctional. They flew him home to Walter Reed. He essentially wandered around Walter Reed for a full year, unable to be returned to not only active duty, but his home. Cognitively impaired, now testing in the, quote, normal range, being told you are normal. What are you complaining about? This is a state judge with an IQ that's average. I don't think so. While he was there, he got a little bit of cognitive therapy as well. He got all the other therapies, and he had some improvement. Not significant. And Dr. Zant gave his wife the protocol that we've been using for years, and we went down to George Washington, got treated, and he's back on the bench. Mr. Hoffman saw that, and he was on fire. He visited him, of course, before he went to Afghanistan, while he was at Walter Reed, and now after he had hyperbaric oxygen. Mr. Hoffman wanted this for every injured veteran, so we had a new alibi until, unfortunately, he died last month. So what happened was all those visits occurred with Bill Duncan on the Hill to try to get our appropriation and additional monies. Well, this is General Maney's case, and essentially the IED, the explosion, etc., the improvement, got 80 treatments, returned to part-time work as a judge. He's very active now in the Veterans Court. Well, my little comment about Treat for Free got picked up by USA Today, and I got a phone call from a Boston judge whose son was the Marine machine gunner, honorably discharged, but very impaired, very symptomatic. And what ended up happening, we brought him down to New Orleans and treated him. And first hyperbaric treatment, unremitting headache for 3 years, gone. By the 8th, sleeping all night for the first time in 3 years. By the 12th, energy up, tolerating crowds. This is the timing of we had the French Quarter Festival every April in New Orleans. 400,000 people on the streets, and he was able to go down and tolerate crowds where he'd been previously very reclusive. And then by the 25th hyperbaric treatment, he came in and he said, my PTSD is gone. I'm not having nightmares, I'm not waking up on the floor every morning after my nightmares told me out of bed. And by the 39th, he was markedly improved. I published the case in Biomed Central's Cases Journal. He went on to get additional treatments, and he just sent me in May. He graduated with a master's degree. And he's just doing great. Here was his imaging, and we reverse them sometimes to confuse, instead of before on the left and after on the right. If you just look at the gestalt, and this was apparent on the imaging that I believe Dr. Reiner put up yesterday, the one SPECT scan, it's heterogeneity. So if we injure all the white matter tracts, downstream transmission is going to be affected. And since the white matter projects to so many different areas, you're going to get a heterogeneous pattern of brain blood flow, which is very abnormal. And if you look at that, so you can have areas also that overcompensate. So we have high flow, low flow, high flow, low flow. And if you look at that, you see the spread of, we've got high flow, high flow, low flow, and this distributed irregularity, which now is a general smoother appearance. You can see it on really every one of these rows. If we look at it up close, again, you can see that there's more variability in the pattern on this right side than there is on the left. This is the more normal pattern of brain blood flow, where it's in a normal range at rest, which translates to very little color variation on a multicolor format. Well, here was his 3D. What were the classic areas that I showed you on the little picture there before with blue, purple, and pink. The contusion areas are orbital frontal lobes right above the eyes and anterior temporal lobes. Look where the damage is here. And after that month of treatment, not cured, but much better, and consistent with the 3D that or the transfer slices. So what happened is then treated a string of these cases, and Bill Duncan ended up at some kind of social event in Washington where Admiral Walsh, I believe it was at it, and Bill was standing there and talking about hyperbaric oxygen, and actually Admiral Walsh started by saying, wow, we got a terrible problem with sailors and Marines with traumatic brain injury and PTSD, and Bill said, well, we got a treatment for you. And the next thing you know, because of all of the noise that Bill and Mr. Hoffman had made on Capitol Hill and really been putting the military on the spot, resulted in this presentation with the Bureau of Medicine and Surgery of the Navy for me to present this information. So on August 14th, 2008, I went there, and the sole purpose of it was to ask for funding to do the study that we wanted to do. And they had a esteemed group of people that they assembled. It turns out 3 of the 6, and part of the group of people that was driving this were the wives of the Joint Chiefs of Staff. Moms are a powerful force. In the audience were 3 to 6 cases that I had treated, requested for funding, and I was told at the end of it, Dr. Harsh, funding is the least of your problems. We have $900 million. I said, wow, that's comforting. So we're funded. Well, no, we weren't. It was retracted, and we didn't get any money. So we had to raise money. But unbeknownst to us, a group of doctors had sent a letter right before my meeting announcing that they were the gold standard for 4 decades in hyperbaric medicine, and they wanted to assist with the establishment of a steering committee to guide them through this process on the best way forward. Well, NASG had asked me, would you please help us put this thing together? So I reviewed the upcoming Air Force TBI study, and I said, look, here's the problem. We've got 2 doses of hyperbaric therapy that have never, ever been applied to chronic mild traumatic brain injury persistent post-concussion syndrome. Now, we're doing rat research. There's no big deal here. You can do rat research all day long. Who cares? But the results of this, with the imprimatur of Air Force Department of Defense over it, it's going to be very hard to overcome if you misfire on it. And we know in children that this has bioactivity in chronic brain injury with CP. We don't know what either of these doses will do in chronic brain injury, but we know we didn't get improvement in the years that we were treating excuse me, all of our diabetic foot wound patients who had previous strokes, traumatic brain injuries, and so on, over decades of time. It wasn't until we lowered the dose and came down that we started seeing gratuitous improvement. And so I told him, you really should not do this. And on top of it, excuse me, I produced a study that was done out of China that showed in moderate to severe TBI in the subacute period, where they did a 2-atmosphere study, they had an 11% seizure rate. Grand mal seizure, oxygen toxicity, 90 minutes, etc. And this was ignored. And a consensus conference was convened in Alexandria, December 5th and 6th, 2008. And a white paper before the conference was submitted that said that hyperbaric oxygen at this dose was safe, because there was all sorts of discussion. What you're doing is unsafe. You're putting our sailors, our Marines at risk, et cetera, et cetera. And we said, well, geez. Actually, I didn't put it on here, but I started my lecture with a 4-month-old baby I had in my chamber down in New Orleans. And I said, you know, I can put this baby in this chamber, and you can send U.S. servicemen to Iraq and Afghanistan and get blown up, and what's the greater risk here? So anyways, we had 60 experts there, and we had they divided us into various working groups, and we were put in the protocols group, Dr. Duncan, myself, and a few others, and it was the fight of our life to try to argue about the control group, and we kept trying to say, look, there's bioactivity here, you're going to put an unknown in, and we've got 700,000 injured that are depending on the results of this study. We can't misfire. Well, we were overruled. We were then asked to lead all of these DoD studies, and 4 days later, Bill Duncan got an email, and we were told to go our way, do outside influence. So it was after we were invited back to a meeting in January 2009. So what we ended up doing was we went out and we raised a small group of us, Dr. Duncan, Mr. Hoffman, myself, $653,000, and that's how this study was done. We did the LSU pilot trial. And we had a gap in the midst of it with funding, and it just so happened that we were right at the halfway point. And so that became the data set that got reported and finally published in the Journal of Neurotrauma. Well, we got all the data now, and it should be published late this year or next year, and it's very impressive. What we also did now is I went back and I matched all 29 of our veterans to normals that I spec-trained in the late 90s, 98 to 2002 under LSU IFB approved protocol. And what we were able to show is that the veterans' brains before hyperbaric treatment are statistically significantly abnormal compared to our normal group. And after 1 in 40 treatments, they are statistically indistinguishable. So I guess we would have had to have amazing placebo to completely normalize brain blood flow. So anyways, the protocol is what it is, but we compressed this, and this was part of the problem. There's an urgency. I want to get this thing done. We've done this a lot on people over the years, twice a day, but there are side effects with it. And especially with PTSD, we found there were some side effects. If their percent back to normal rating was less than 90% after the 40 treatments, they could do more. It turns out we had no money. So everybody only got 40 treatments, and I'll try to roll through this kind of quickly. We started in September of 2008. We had one dropout. He had an ear infection, bullous meningitis, and barrel trauma. He had to stop. He had a hard return date for plane flight, and so he couldn't complete it, and we just he had to drop out. But I reported the 15 at the International Brain Injury Association meeting on March 12th of 2010. 3 days later, Dr. Duncan, Dr. Mosiani, Mr. Hoffman, and the group had a meeting with the Army Surgeon General where we promptly told that all this was placebo. And what we found was this significant improvement. We did a 6-month phone follow-up, maintenance of gains. Dr. Duncan put the one quote up there for you. In one of the blistering critiques and letters to the editor, we responded by, our statistician actually was a little pissed off because they were trying to claim his statistical analysis wasn't quite right. And this is a Georgetown University academic statistician, John Pizzullo. And John did the numbers and said when you have 15 of 21 outcome instruments, or 16 of 21, all showing a statistically significant change, even without a control group, the chance of a chance occurrence of that is 1 in a quadrillion. So here was our average time to treatment. It's 2.8 years out. And that's what we found was, in terms of safety, 5 had middle ear barrel trauma. What happens? You're doing this twice a day. Hyperbaric oxygen therapy is mildly immunosuppressive. What would happen is we found a number of them would develop an upper respiratory infection, and they're in the chamber and in the prodrome, you're swelling up mucosa. They don't know until they can't clear their ears. And so we had to take some breaks, give them some time off. The one dropped out. 4 had transient deterioration in symptoms about halfway through, emotional lability, headaches, depression. 2 had a worsening of anxiety. 1 had to meet in the emergency room over. A guy with PTSD had gone off his medicines 9 months before. And I really think it was due to the rapidity and intensiveness of the protocol. It's okay. You go slower, it's a little easier, you can adapt, and so on. But here it is, the symptom. We had improvement in across the board, pretty substantial. 64% of those on psychoactive medications decreased their medication use. 6 months, those who were improved right after the treatment or said on their primary symptom thing, unimproved, maintained it. One of the guys who said, I got nothing out of this, he called up and asked if he could come back and get more. He then said, yeah, I do better. And here were the statistics for full-scale IQ, delayed memory, all the neuropsych testing, and the p-values. Some things we didn't get significance with, but that's for the first 15. If we look at the symptom questionnaires, the River-Mead, which is part of the DoD studies, the PCLM, which is the PTSD, the post-traumatic checklist military. What I wanted to do, we designed this to use some of their instruments. So if we hit significance, it could be claimed, well, you didn't do what we did. You didn't measure the same thing. Depression, a significant reduction, almost 50%. Anxiety, similar. Perceived quality of life, marked improvement, they felt better. And the imaging changed as well. And if we look at the heterogeneity, what this is showing, these are the amount of counts in their bins, you call them. So let's say we take a pixel, and 5 to 10 counts, 10 to 15, 15 to 20, etc. And what it's showing is that we have a range of blood flow. The average is right here, or I should say that's the median, but it's kind of a bell-shaped curve. That's not normal. It gives you this irregularity. After hyperbaric treatment, you see what happens. This narrows, and it becomes a little more confined, which is a more normal distribution. Well, we also did statistical parametric mapping, and here was after 40 treatments. Significant areas of improved blood flow are in red. P-value of 0.001 was our threshold, which is a conservative one. The rest of the brain. We also then looked at the hippocampus. We had statistically significant improvement in memory function. What's the short-term memory organ of the brain? The hippocampus. So we had the computer dissect down the hippocampus, and you see after one treatment, we partially light up the right hippocampus, a little bit on the left, and you can see it here. But look what happens after 40 treatments. We have marked improvement in blood flow, consistent with the improvement in memory. And here are just the additional pictures of the hippocampus. Okay, so what happened was, we then did the statistics on 24. I didn't put the 29 up here because we're in the process of submitting it, but this has moved over further. Our IQ1 is a p-value of 5 times 10 to the minus 7. Now granted, we don't have a control group, but everything was directionally in the same direction. I mean, if we now run the statistics on the 1 in quadrillion, it's going to be 1 in Avogadro's number or something like that for a chance thing. But you can see what's happened is the p-values have strengthened, if you will, on most of these. There are things we didn't get as significant, and here they are, just comparing them and what had happened. So it was pretty reproducible. So essentially, in 1 month hyperbaric, significant improvement in symptoms, 15-point increase in IQ. Actually, now that we've done all 30, it's a little more, closer to 14 points. Significant increase in cognition. 8 to 14 no longer met the criteria for PTSD. I haven't seen this in any PTSD study that's had a similar conversion rate, if you will. 51% reduction in depression, 38 in anxiety, and the percent back to normal rate that veterans saying, how do you feel now? How much improvement did you have? They estimated it was pretty good. So what happened, we got our appropriation, and that was in September of 2008. You have to take delivery of the money because it's in the next fiscal year, or the final fiscal year. Well, we started calling to try to find out where our money was, because it never got sent to us. We kind of were told, well, we can't find your appropriation. We don't know where it is. It's kind of someplace. And we finally tracked it down, and we had to get Louisiana senators and congressmen to get on the phone to get this deposited 2 days before the thing expired in 2009. So we finally got the money, and then it started, well, wait a minute, I know this is going to be heavily scrutinized. I've got to dot every I, cross every T. The Army had gone to the FDA and got an investigation of new drug exemption. Now, for the entire history of hyperbaric medicine, as I talked about yesterday, hyperbaric medicine has been under the devices section, Center for Devices and Radiologic Health. And so it was like, well, you know, I don't understand why they're going to the drug side. So we started with that request I described yesterday of, do we even need one of these? Is it a significant risk? And the long story short, we finally got approval by the FDA, the Army, LSU, everything, May 8th of this year. You see when we started. But what happened in the process was, you know, we asked them, you know, would you accept our protocol so that when we're done with this study, and it's a randomized controlled design, we will be able to apply to you to get a new indication for hyperbaric oxygen. And they said no, because of this whole pressure thing. We want pressure controls. But there's no way to do that adequately. There has never been a pressure control in hyperbaric medicine where you actually tested the people to find out if they got fooled on which group. So what ended up happening, Marty Hoffman then went to DARPA to get a $2 million grant, which he did, and that's the one that got appropriated to Dr. Sifu. We attempted to combine these, and we were all in agreement, and suddenly the next day, I was told that it would be an impossibility. I needed to go my own way. So we then started ENBER, got the FDA answer and what we had to do. The pre-IND request, went through that, your combination, your intervention, a combination therapy, and so I did the literature search. We found out all of this stuff and how it explained it. It underscored what we were trying to say at the consensus conference about the error in doing these, quote, sham air pressurizations. They're not shams. They are all treatments. In the process, out comes the Wolf study. It finished up, and this was the Air Force study, 2.4 ATA versus 1.3 atmospheres of air, single center, double-blind, sham-controlled, not. 50 military members transported to San Antonio, where they spent the time there doing the study. They had to have at least one combat-related mild traumatic brain injury. And there was the protocol, 90 minutes for 30 treatments. Anybody ever seen this anywhere? Never. So we're testing, the whole consensus conference, by the way, was called to either validate the cases that we were showing at an atmosphere and a half or not. That was the entire reason for that. And out of that, this had already been underway, as it turns out. They applied for it, but the study didn't start until well into 08, I think 09 was when they put the first patients in. But if you look at this, here we are with a protocol that had never been done before. They used the IMPACT, which is a computerized test, and PCLM, military's PTSD checklist, and a bunch of other outcome instruments. They measured it weekly and then 6 weeks. But to this date, they have only reported the symptom portion of the IMPACT. We can discuss that later, but the results were no significant difference in the post-treatment means on the IMPACT or PCLM between groups. And this is key. What they did was measure the average score at the end for each group, and they compared the two groups. That's fair. You assume one's a control group. That's the way studies are done. But they also looked at within-group improvement. So you take each person and you compare their score at the baseline to their score afterwards. You get a value. You do that for everybody in the group, and you take the average value and you see, did they improve? Did they not? Did they get worse? So we have within-group and between-group comparisons. That's the way you do a study when you're trying to test a treatment, a drug, whatever. Keep that in mind. Conclusion. Well, what they found were statistically significant improvements in both groups. Conclusion was HBOT at 2.4 ATA pressure had no effect on post-concussive symptoms. I'm sorry, it did. Your data showed that. It didn't compare to your control group, which was another therapy. What this was, though, was a dual dosing study. So let's look at the graphs. And this is the PCLM and our two control groups, control and hyperbaric oxygen. You see that both of them improved over time. And actually, by the end of it, they're starting to lose the effect. What is that? I mean, was it too much? I don't know. But you're starting to lose the effect there. And at 6 weeks, you would seem to lose a little bit more. One did not change, but you come up a little bit. Still, though, pre to post, both groups had significant improvement. It's almost a 10% improvement by the numbers. And here's the impact, though. So the cognitive symptoms, and if you look what happened with the control group, they had an immediate worsening by the end of the first week, but then a steady improvement that even improved 6 weeks after. What happened to the 2.4 ATA? We get an improvement, and then we lose the effect. What is this type of effect? And then a rebound to improvement after you stop. This is the toxicity response in hyperbaric medicine to hyperbaric oxygen. It's what I put in it's in the whole chapter in the 2001 symposium book from the Neubauer conference, where Dr. Neubauer asked me to give a talk on the dose of hyperbaric oxygen. And I said, well, you're probably not going to like this. I know you recommended 200 treatments to my first diver, but in fact, I'm finding that we're getting into trouble with some of this. As we hit about 110 treatments or so, and people using the 90-minute protocol, actually 90 minutes, we're and getting it back for about 65 treatments. At 60 minutes, it was up in this range. And so I showed 33 cases there, and this was the same type of pattern. And he wasn't happy about it, but I mean, it was the data is what it was. So I wrote a letter to the editor pointing out what they had done, and then I quoted all of this literature that I showed you yesterday from the review by McDonald and Fraser. Please get that and read it. But all of these biologic effects with micropressure. To this date, there is no published response. I don't know if you realize, if somebody attacks, I should say attack, I kind of did, but I mean, if you write a letter to the editor against a journal article, challenging the results, and essentially are claiming that the results are totally invalid. I mean, the first thing happens, the editor goes to the authors of the study, and then they send it to others to peer review it, and you respond. And you got the bully pulpit. You've got the last response. You don't get, the guy who writes the letter doesn't get to come back and object. So you get the final word. There has been no final word. There is none. It's just been left like this. It's a hanging chad. What essentially was a multi-dosing study with 2 effective doses of hyperbaric oxygen on TBI and PTSD, plain and simple. Okay, now there's got to be some placebo in it, I'm sure. But what also happened was that I know George Wolfe. He's a decent man. And I immediately sent him an email, and I said, George, look, I'm sorry, I'm going to write a letter to this. And he said, yeah, I know. He goes, but it's okay. He said, but I'm not the corresponding author. I can't even respond to you. And I originally called him up to alert them to the fact that if you went online, the data and study was uploaded, there was no data. It was just text. None of the data got online. I said, wow, you guys published a study, you got these negative conclusions, there's no data, nobody can even look at it. And he said, I wasn't in charge of that, I didn't upload it. So they took the thing down and got corrected to someone, but he has not spoken about his own study. He is not a corresponding author, which is odd. Okay, let's go to the next one. So this is now the DARPA study that Marty Hoffman got the funding for. This was to be a combined one with what we're doing now. It got done in, single center. Everybody got transported to Pensacola Beach. And I will argue, of all the places now the DoD studies have been done, where do you think might have the greatest placebo effect? Pensacola. Sun, sand, beach babes, I mean, come on. All of these injured male veterans, where would you want to go on TV? And you're going to see, these are the most muted of all the results. So 60 service members in 3 groups. Now study, this has already been reviewed in understanding hyperbaric medicine with sample analysis, and what's been claimed is that all of these studies that are being done by the DoD are underpowered, potentially, to even get positive results. One answer, let's say that. Well, a positive result. But they had to have one related, combat-related TBI. So 3 groups, 2 atmospheres of pressure. So we compress on air, rising PO2 and pressure, and then in 2 atmospheres you put on a hood and given a hypoxic mixture that gives you normoxia at depth. Where's this been done in TBI? Nowhere. Nowhere. Again, 700,000 injured people at least, just in the military, depending on data, not a rat study. The other group got the dose, quote, typically used by hyperbaric practitioners or aficionados or something like that. Hyperbaric practitioners, I think. And then the other got 2 atmospheres of pure oxygen. 60 minutes, once a day, 40 treatments over 10 weeks. Rivermead post-concussion symptom questionnaire and the PCLM immediately before, post-treatment, and then multiple other outcome measures. A whole bunch of them. But this study just reported this. And results, the between-group testing showed no significant differences on individual or total scores on the PCLM or the Rivermead. So again, assuming our control group is that 2 atmosphere pressurization with normoxia at depth, calling it a kind of room air equivalent with a control for pressure, they don't see any difference between the groups. Okay, well that's between group testing. If you look at the within group testing, there are significant differences on several individual items for each group. And the 2 atmosphere oxygen group had a statistically significant improvement in PTSD. Conclusion though is hyperbaric oxygen, either 1.5 or 2 atmospheres equivalent, had no effect on PCS symptoms after MTBI compared with sham. Okay, well, how about the PTSD? This is a study on, you did 2 outcome instruments, 2 primary outcomes. You treated PTSD and you treated post-concussion syndrome, and you should report the data. But as you look at it, it's not in the title, it's not in the abstract conclusions, and it's not in the conclusions of the main article. You got to dig this out. The study essentially showed there is effectiveness for 2 atmospheres of pure oxygen, 60 minutes once a day, 40 treatments on PTSD. And it compares favorably to other PTSD therapies. It kind of is consistent. It's very consistent with what we did at 1.5 atmospheres. It's consistent with the Wolf article as well. But the results are not in there. Or at least it's not. You have to dig it out. Well, that study has now been reported in 3 segments. So the next part in publication is in neurorehabilitation and neural repair. And by the way, I wrote a letter to the editor to point this thing out, and it was rejected, and he said, we'll deal with this in a editorial issue sometime in the future. I haven't seen it. So now, additional data is presented, and this is going to be the harder outcomes: computerized posturography, group, pegboard, multiple neuropsychological tests. And what they did was no immediate, the results were no immediate post-intervention beneficial effect of 1.5 or 2 ATA oxygen compared with the sham air intervention. Okay, again, assumption that that was a sham treatment. Conclusion, do not support the use of hyperbaric oxygen to treat cognitive, balance, or functional deficits associated with mild TBI and persistent post-concussion syndrome. Well, let's look at the data. It turns out there were 110 outcome measurements, and they talk about outcome. The language in this article is very interesting, but there were 55 different tests done. 55 before, 55 after treatment, okay? And what they did was they took and they calculated an ANOVA for each individual test, comparing the 3 different groups before. And then they went and separately took the same group for the same 3 groups for the same test afterwards and compared those scores to each other. Turns out 106 of the 110 ANOVA p-values are insignificant. So anybody looking at this article, any doctor, how do you go and pull an article on PubMed? What do most doctors do? You don't have time to sit and dig it and go through all the complexity of an article. Most people, how many people are expert in this stuff? I mean, they read it, find out, can't help my patient. Pull up PubMed, there's the abstract, look at the title, look at the introduction. Conclusion, didn't work, done. Hey, it's a study with a negative result. And when you look at 106 of 110 p-values that are negative, what's the conclusion you draw from that? It turns out, though, as I was talking earlier, you measure each person before, you measure them after. You get that value, you average it for each group, then you compare between groups. You do within group and between group. There is no within group or between group comparison in the entire study. Go look at it. You will not find them. In fact, there are no treatment effects reported at all because the statistics don't allow you to do that. And if you look at this, so here, let's just take group pegboard. Sham air, 2 atmospheres, 1.5. Here are the number of veterans that were in each group. Here are their mean scores. You can see there's a little difference here, 66, 72. Standard deviation is fairly high. But when we compare these 3 numbers with those standard deviations, there's no significant difference between them. Okay, cut. Now we go to post-compression. We retest them. We don't measure 66.3, 67.5 minus 66.3 and get a number, or 68 minus 66, or 70 minus 72. No, we take those 3 and we compare them again, standard deviations, and we have another insignificant p-value. And you can run through the 106 of those. So, what was the treatment effect? You can't tell. It's not published. But if you're going to take what I did, wrote a letter to the editor, summarily rejected, and I pointed out to them, well, let's just take your 4 significant ANOVA values before, and let's really calculate and see after the p-values are insignificant. So where they look and go, well, oh geez, this were abnormal before, but now they're normal, so the treatments have no effect. Well, what it's saying is you had a differential. First of all, this is saying, is there variance between these groups? And it says yes, meaning the score on this test for these 3 was a little bit different. Doesn't tell you who was different, who was low, who was high, etc. Well, it did, excuse me, it told us on the other one, but the point is, it is significantly different. Afterwards, though, they're now not significantly different. But if we look at the difference from pre to post for each group, you can see we got a 0.6 change here, a 0.4. Whoa, we got a 2.6 change. This one improved by 31% in the 1.5 ATA group, and the others had lesser improvement. Well, if you did this for the California Verbal Learning Text Indexed Recognition, and we do the same thing, look at this, a 17% change here, a minus 140%. They did worse at that dose, and a whopping 78% improvement there. Go down to the California Verbal Learning Test, short delay cue recall, same thing, 5.7, 2.4, 27%. And you can do this, now I didn't do this for all 55 tests, but I was trying to make the point to them and show that here is the treatment effect, and what we're seeing is that we've got some differences. If we go down to this one, and this is what I want to show you with a kind of analogy here, and we look at the differences, all 3 groups improved almost 20-some%. It's a big change. But if you look at all 3 of them compared to each other afterward or separately before, p-values are insignificant. So in my letter to the editor, I said, well, this is real simple. For an analogy, let's do a diet study. And we're going to do 3 diets. And we're going to look at the effect of diet on weight loss. So we're going to measure the effect of each diet on 3 groups of people, equivalent to 3 doses of hyperbaric therapy on veterans with TBI and PTSD. So you weigh each patient before the diet, and you subtract that from each patient's weight after the diet. Then you sum, for everybody in the group, the average weight loss or gain, whatever, for each patient, each of the 3 groups, and you compare them between the groups to find out how each therapy did. So essentially, to measure treatment effects, you measure within group differences for each subject, take the average for each group, and compare the differences between groups, so you get between group comparison. The difference between each group gives the efficacy of each diet on weight loss. Okay, so let's do the sham diet, the Subway diet. We're going to do the bologna diet, and we'll do the deep-fried New Orleans diet. And we all start at 300 pounds, okay? Actually, New Orleans, we're number 1 in the country. We should be 350. But, and what we're going to do is compare. We're going to do exactly what they did in the study. So let's take an ANOVA, and we want to see, are these 3 groups different? Well, ANOVA would say, there's a pound difference there, there's 2 pounds here. No. So we've got a non-significant ANOVA. Now let's look at what happened after each of these diets. Well, these guys lost 60. These lost 58 pounds. And these lost 62 pounds. And so we now compare these 3 values to each other, and guess what? You notice says they're not significant. Whoa, wait a minute. We each lost around 60 pounds. It's almost 20% of body weight. By any standard, it's a good diet. Even the deep-fried New Orleans diet, they were all good diets, right? But within group significance, well, there's significance there. And between groups, though, it is insignificant. This is exactly what was done in the reporting of the statistics and the data in this study. So, really, what's the conclusion of my diet study now? Dieting had no effect on weight loss compared to sham diet, the Subway diet, right? And that's exactly what the conclusion was in this study. So really, the true conclusion is given the methodology, the data reporting, and the analysis. It's impossible to draw conclusions from the study. You can't tell if hyperbaric oxygen in any dose had any effect on cognitive balance or fine motor deficit in subjects with mild traumatic brain injury, PPCS, unless you go and take and measure each one of those. Well, we tried to do it and I took it to our statisticians at LSU and asked them to run the statistics on it. You can't do it because the standard deviation of the difference is not reported in the study. All right, so let's look at the third publication on this study. This is now in the Annals of Neurology. And the outcomes here are going to be the symptom questionnaires plus everything, functional, cognitive, psychomotor outcomes at 3 months. And I want you to read this. All the doctors here in the, because your doctor is supposed to know statistics, right? The interaction of time by intervention group was not significant for improvement, nor was there evidence of efficacy for any subgroup. No significant time by intervention interaction was found for any functional, cognitive, or psychomotor secondary outcome measure at an unadjusted 0.05 significance. What the hell did that say? Those are the results, and did it work or didn't it work? What's that?
The guy was really smart because we couldn't understand him.
That's exactly right. This is really brilliant the way this is done. So using a randomized controlled trial design and analysis, including a sham, results show no evidence of efficacy by 3 months post-compression to treat all of this stuff. Well, let's take a closer look. If we look at this, what they did was what's called an F-test on all the data, which is the variance between treatments. In other words, between groups, or the variance within treatment, within groups. So it's a between group over a within group. Okay, it's an ANOVA type of thing. It's kind of a complicated thing. What it basically looked at, did any of these things have any effect on the outcome of the study? The changes that occurred over time, and essentially none of them did. Loss of consciousness, you know, post-traumatic amnesia was really one of the only ones there. Actually, PTSD did, excuse me. The McGill questionnaire, they did. And if we look at hypothesis tests for the treatment by time interaction for the secondary outcomes. Okay, what are these? All right, so we look at, did it work or didn't it work? And essentially we've got a lot of insignificant p-values, so I guess this didn't work. But the one graph that they put in there, if you look at this, and this will explain the F-test, what they did was, at each time point before, after 1 week, and then at the end of the study, they compared the 3 groups and they ran the ANOVA on it. So they're saying the values here weren't statistically different from each other, nor were they here, nor were they here. But if you look at this guy started here, this group, and they ended up there. We got a difference here. That group didn't change at all. And this group, excuse me, went from here to here to here. We have change. But what's the pre-post? You can't tell. So here are the hypothesis tests for subgroup efficacy analysis. Again, a whole lot of negative or insignificant p-values. And here's the results. Although not relevant to assessing intervention efficacy, because we declared that sham treatment a sham, when in fact it's another dose. But although not relevant, some secondary outcome analyses did show significant effects with one or more explanatory variables similar to the primary outcome. Following measures were all statistically significant, irrespective of treatment. Well, you can't even tell which treatment produced it. But what they showed was, on all of these cognitive tests, they had significance. Where do you find the data for that? It's not in the paper. It's a separate download. You got to go here in the supplementary data tables to get it. And so if we look at the supplementary data tables for working memory, well, significant. And what it means was memory, here it is, baseline measurements were lower than the 2-week and 12-week measurements. Well, what's that mean on memory? Your memory was worse before you started, and it was better after 2 weeks than 12 weeks. Okay, why don't we say that? Memory was improved. Oh, I'm sorry. Whoa. Get excited here. Okay, so there's working memory. Well, we can do this for the others. Here's executive function. Same thing. Significance. Here is California Verbal Learning Test. Significant change. The SAT. controlled self-attention, executive function, significant value. Event visual memory test, significant. CALET letter fluency, verbal fluency test, significant. So what are the results of the Annals of Neurology secret paper? Did hyperbaric therapy have any effect or not? By the data, no treatment effects were ever measured. And the conclusions were predicated on this 2ATA air sham group. The true conclusion here, you can't, even with those figures, it doesn't tell you which of the three groups changed. It just tells you that overall at the end, there was a significant change from the baseline. You know, there are words that can be used to describe this, but I don't want to do it publicly here. They're not swear words, but you know, I mean, what happened here? You put this in the hands of some of the top people with the best reputations. You got DOD over the top of it. And we report stuff like this where you can't even figure out what's going on. And the true conclusion here is that it is a multi-dosing study of 3 doses of hyperbaric therapy, which had never been done before, in which the statistical analysis renders it impossible to tell if there was any treatment effect of any dose of hyperbaric therapy. Neither within nor between group comparisons were reported. And last, you know, the Israeli study, and I'm not going to elaborate on it, I think we have to talk on it, but they essentially took the protocol we've used for a number of years, and they did the mind streams, computer testing, quality of life, SPECT brain imaging. They got the same results we've been getting all along, and other people have too. Significant improvements in cognition, no significant improvement in the control group. It was a randomized, controlled, and crossover. SPECT had elevated brain activity with the cognitive improvements, and I mean, what's the conclusion? The obvious, HVT can induce neuroplasticity, leading to repair chronically injured brain functions and improve QOL in MTBI patients with persistent post-concussion symptoms at the late chronic stage. And finally, we have EMBER. We're getting the same results. We submitted it, we just got it reviewed, and we're working with trying to see if we can get it published still. But essentially, symptom improvement after 35 treatments, 8 of 8 NM mood, 6 of 7 NM neurocognitive, and 7 of 10 CNS vital signs cognitive measures were significantly improved. Increasing numbers correlated with improved outcomes. The more you did, the better you got. Up to, you know, we looked at 80. And the conclusion was hyperbaric oxygen in an atmosphere and a half for 35 to 80 treatments, significant improvement in symptoms and cognition. So what are our conclusions here? All the existing data that's come out, if we first start with just the TBI, mild and moderate TBI is primarily a white matter injury. It's why we've never been able to see it. And in fact, if you look at the statistics we did on that statistic and the texture analysis, where did we hit the home run? It's in the white matter. And you can't even read that on the spec. You see it derivatively in the gray matter downstream. Mild and moderate TBI results in primarily white matter wounds. We have a treatment for wounds. There's no two ways to argue that. There's accumulating evidence that both in veterans and civilians, which all of us have been doing for many years, the Israelis now have done this study in civilians with MTBI showing benefit of multiple doses of hyperbaric therapy immediately after treatment. Don't have long-term follow-up. I've got a 6-month phone follow-up, and we're doing a 6-month cognitive follow-up we're testing right now in this study. DOD studies are showing benefit, but it's complicated by confusion of the sham groups and inadequate statistical analyses. Ideal dosing? We don't know, but we got enough to treat now. And lastly, you know, we talk about all this data. These are all real people, and this is part of what gets lost in all the, you know, clinical trials. This isn't rat research, and this is why we were so adamant about trying to do these studies right the first time around, because as you can see now, all the negative press that's been put out, you know, trying to fight the DOD's name on studies that have been improperly done. Oh, the DOD did that to prove it was, you know, you hyperbaric people, you're just, you know, fantasizing. But these are real casualties. Thank you.
Thank you, Dr. Hodge. We do have 7 minutes for some quick questions before our panel discussion. So the first hand, I'm sure, is about to go up. Bill.
I'll just make a quick comment. when the reporters came to see me in Oklahoma City, they said, quote, "We looked this up on the internet. How come VA and DOD were the only ones that couldn't get this to work?"
Well, you know, when we first started doing this and talking about it, the very first things that were published in newspaper interviews with the Department of Defense were the quotes that this was going to bankrupt things, that the average cost to treat the veteran was $500,000. And that's the real reason, I think, behind all of this. They're afraid of short-term what it might cost, especially when you look at a $2,000 an hour hospital billing charge, you know, 80 treatments for $160,000 right off the bat. So you know, unfortunately, it's a very short-sighted approach. But in the military, you can do things very, very inexpensively. So it was a convenient objection, but really didn't have any evidence to it.
Thank you. We have our next question.
Thank you very much for your presentation. You mentioned functional MRI. How accessible and compared to that SPECT scan?
It's not that accessible, and it's equally expensive, but it is not that accessible. And functional MRI also, there are a number of different ways that it's done. You know, some of them will do task-specific one, looking at visual function, motor function, and cognitive function. And it depends on the test they're doing and so on. We don't have access to it, and we've used SPECT for so many years. We've done the normals, you know, introducing yet another imaging technology here. We don't have a base to rely on, and it's kind of like starting over. But I encourage anybody to use it because you'll be seeing the same thing. So we're measuring the same thing with SPECT, with functional MRI, with QEEG, and what Adam Reiner, you know, the way the brain works, it is consciousness directs activity, electrical activity, and metabolism. I should say metabolism fires up, electrical activity results, blood flow simultaneously. And what he's measuring is electrical activity summed over these areas, a little bit larger size areas, but it's all the same.
Thank you. We have a few quick questions.
Well, thank you for your persistence. In the article that you published, the letters that came back talked about the learning curve on a lot of these psychometric tests. And obviously, I have no expertise in that area. Can you address that issue? Isn't that true of any repetitive testing modality? And is there something that you could potentially use that's harder, that you can't relearn?
First of all, we addressed it in the actual article, and they just overlooked it. We talked about it because one of our outcomes was working memory. And I quoted the figures in the study with placebo experiments showing the amount that you get with placebo effect. And our delta, our treatment effect, was far greater. So there are some of those that are very, or pretty much independent of practice effects, learning effects, and so on. And we addressed that in our response to the letter to the editor. So you try to pick ones that have alternating forms. And we had some of them in there, but we've got more in the current study that we're doing. What we looked at, though, was all the placebo data. Where have our tests shown a placebo effect, and to what magnitude? And we try to compare them. In this future article, we're going to use what are called reliable change scores, where it looks at testing that has been normed, and they have looked at significant change independent of placebo effect, and we still have it, even without a control group. So, yeah, that's a big question. With the ANAM, in fact, the learning curve is about 3, 4, 5 repetitions of it to get to a plateau so you don't have a learning effect.
Thank you. We have our last question.
You may have addressed the issue of medication. Having trained as a psychiatrist, I know that many of the psychotropic medications can have lingering effects. So were these folks off medications, or any of them on medications, and did you look at that impact?
We did. It was variable. We had some who quit the day before they started the hyperbaric oxygen, unbeknownst to me. You know, we had told them we didn't want anything changed. They showed up, they said, I want off these medicines. You know, maybe this will help me. They stopped, we did the study, they didn't go back on them. The figure about 64% was 64% of those on psychoactive medicine, while we treated them, stopped using them or decreased their dosage. And so some of them, yes, I know they have effects on cognition, and that's part of what we measured, I'm sure. They weren't as doped, when they repeated their testing, but the key was why they stopped their medicines. What started happening was they felt better, or they started feeling side effects, that the medications previously were treating some pathology that was now corrected, doing better. Ritalin, for instance, is the classic one that we give with children. Once you treat the underlying pathology and they start improving the attention deficit, when they take the Ritalin, they get the speed effects that an uninjured person would get. And so they stop using it. And so we factored all of that in, we explained it, we said, look, we know there's got to be placebo effects in here, but look at the magnitude of the size. And we know that all the other therapies out there have placebo effects associated with them. Nobody wants to talk about them, but we put them in the study for comparison. We say, if you just compare and do a, therapy to therapy, you still can't discount this.
I was actually thinking of the negative effects. In other words, those folks that didn't get the full effect of the hyperbarics, maybe go back and look and see if any of those were on the atypical antipsychotics.
Boy, I got that data right in the computer. We could, I haven't done that.
Okay, can we once again, for his third lecture, show